Now we have Dr. Haimanti Choudhury, who is consultant ophthalmologist in Choudhury High Hospital and Research Center, Silchar, Assam. She is also the chief editor of Journal of Ophthalmic Research and Practice, and her topic is intravitreal injection, procedure and precautions.
Good afternoon all. Before I begin, I'd like to thank Dr. Deepak Mishra for making me part of this very interesting IC Learning from Our Mistake. And my topic is intravitreal injection, procedures and precautions. I do not have any financial interest in this presentation. So when we talk about intravitreal injections, the first thing that comes to our mind is anti-VEGF, but I will also touch upon a little bit of intravitreal steroid and intravitreal antibiotics, which is a surefire way to treat postoperative endophthalmitis. So why are we having this talk? You must have come across these disturbing headlines which talk about eyes being lost after injection. Then when we also do literature review, we have cases of cluster endophthalmitis, both from India and abroad, especially after use of intravitreal bevacizumab. So we definitely don't want to land up in a situation like this, and that's why AIOS, our parent body, and VRSI, along with AIMS, have come up with this very important guidelines for intravitreal injection, especially Avastin. This was published in 2017 and then has been updated. So I will be mostly focusing my talk on that. So one very important thing is to differentiate between authentic Avastin and a counterfeit product. For reference here, the top one is the authentic product and the bottom figure is showing a counterfeit product. So how do we do that? That is done by checking the Kessler code. So when it comes to Avastin or bevacizumab, we have to procure the drug from an authorized Roche distributor. We have to ensure that cold chain is maintained right from the distributor to the user end, and when it has reached the user, it should be in a hospital it should be preserved, refrigerated, and documentation should be done, which will save you in future. So what are the prerequisites before you go for the injection? You have to take informed consent from the patient, and this is also the consent form which is given by the VRSI, and we are also using that. You have to let the patient know about the off-label status of the drug, and then this is just a sample chart where you can show to the patient what are the options that are available to them other than the off-label status. After the consent, the procedure has to be done by a trained ophthalmologist. So when it is talked about preparing bevacizumab, it has to be fractionated and allocated. Allocating has to be done in insulin syringes from that multi-dose vial, and then those are preserved in ETO sterilized packages. Packages are again kept in boxes, which is then refrigerated. Now, on the day of injection, what are the screening that you will do? You'll have to do a negative regurgitation test. Patients, if have any infection, blepharitis, meibomitis, you do not want to do that on that day. You have to defer it. And bilateral injections are not at all recommended. Sugar, we always check, and we want that to be less than 200. So in the pre-op medication, let me directly take you to the OR and show you what is our modus operandi. The first video, when the surgeon is taking the medication, there our staff nurse will start putting proparacaine and 5% povidone alternately, and that will go on for 2-3 times. In the meantime, the surgeon will come, do spirit swab of that eye to be injected. Before taking any medication, the surgeon has to check the box, the surgeon has to check the expiry date, and then we will do and take out the medication. Moving ahead, the box has been checked, and now the top of the vial has to be cleaned with alcohol swab. And then taking out the medication is again different for bevacizumab and different for single use. The right-sided video is eccentrics. So eccentrics, there is a dedicated needle with which it has to be taken out. And for bevacizumab, of course, it is allocated in syringes, as I have already shown. Now, since this is a mistake session, let me also show you a mistake video. The bottom video, left side, is a mistake video where you are seeing the patient is sitting in a OPD chair. There is no draping and the surgeon is going for the injection. So in our Indian scenario, this is a mistake. We would definitely not do that because this is not recommended by the VRSI and AIOS guidelines. In contrary, this is the video, the fourth one which is running now, where we are preparing the patient with 10% betadine. That we would do for any other intraocular surgery. We have to treat injections like any other intraocular surgery, draping and polythene draping, all has to be done. Coming to another mistake video, you will note a staff nurse has just injected this lady. But in India, it has to be done by a trained ophthalmologist. Again, our preferred quadrant is inferotemporal, but it can be any quadrant of your choice. After putting 5% povidone iodine, we are marking with the caliper. It will be 3.5 to 4 millimeter, depending on the lentil status. After it has been marked with the caliper, again 1 drop of 5% povidone has to come in. Then a brand new 30 gauge needle is used. It is not the needle with which you had taken out the drug, certainly. And then this is plugged with a cotton, and then again there is 5% povidone being given. Next, again a mistake video. You will note here the surgeon has marked the area and then the surgeon is going straight ahead and giving the injection. This is a mistake again because in the guidelines it is mentioned very, very clearly that the last substance that touches the conjunctival cul-de-sac prior to your injection should be 5% povidone iodine. There are no two ways about it. Now the fourth video here is a intravitreal steroid injection or Zurdex. So the bore of the needle is thicker in contrast to your 30 gauge. So you will note something different is being done here. With the cotton bud, we will displace the conjunctiva and then put the 5% povidone so that there is no egress of vitreous. Moving ahead, we also sometimes do injection with cataract surgery. Here you have seen a cataract surgery is done and you are seeing the lens is in situ. The visco wash has been done. Now again we will put povidone iodine, mark the area, give the injection, and there is one extra step that is being done here, and that is the reason why I am showing you this video. After the injection is done, we just have to tap the cornea a little bit to know if the eye is too hard. If you find the eye is too hard, you just have to let some aqueous or BSS out from the side port. Moving ahead to our last video, this is a trolley which is used for intravitreal antibiotic preparations. Now for intravitreal antibiotics, commonly what we are using is for gram-positive vancomycin 1 mg per 0.1 ml. And for gram-negative ceftazidime 2.25 mg. So this is the making from 500 mg vancomycin, but also vancomycin is available as 250 mg. Here it is you are seeing 500 mg vancomycin being mixed. So now 10 ml sterile water has been inserted inside and then only 0.2 ml of the solution will be drawn. Here what I'd like to emphasize is each time that you are taking the sterile water, you will have to use a new needle. Why? Because some amount of drug is present in the hub of the needle and this can change the concentration. So to have an accurate concentration, you will have to keep on changing the needle. Now this is again another rotatory movement that you have seen in the video, and we let the air pass from down to up and again vice versa so that the mixing of the drug is done properly. And after we have achieved the requisite concentration, we will again mark it and then move ahead and do the preparation of another drug. So what is the post-op management? Recommendation is you have to see the patient within the first 3 days. In our setup, we see the patient on the first post-injection day, and that day you have to check for the IOP and slit lamp evaluation has to be done. If there is any IOP increase, we have to manage that. So what are the 5 mantras to avoid infection in injection? Those would be: perform the procedure in OR, be like a surgeon using all mask, cap, and any think it to be your cataract surgery and just go and do injection. And iodine prep, draping, and speculum must be put. Thank you very much for your kind attention.
Thank you, Dr. Choudhury, for a very insight talk.